Hello, my name is Tammy Walker-Smith, and today I will be talking to you about the human papillomavirus vaccine and disparities among Hispanic females. The HPV, human papillomavirus, significance is that over 20 million people are infected with this virus annually in the United States, and it is the most common STD worldwide, especially in the United States, but worldwide as well. And 37.2% of college women are infected on an annual basis with this virus. It is a sexually transmitted infection. Um, the HPV vaccine was made available to the public in 2006, and this vaccine protects from multiple strains of the human papillomavirus, especially in particular strains 16 and 18 that are very virulent. Now, youth between the ages of 9 and 26 are eligible to receive this vaccine, primarily that age range because it is before they are sexually active and also to protect them should they become exposed. The immunity is strong at that time when they would be most likely to be exposed to that particular infection during experimentation in that age range. Now, the compliance for the vaccine is for females is only 57.3%. Now, with males, it recently was recommended that males can receive it as well. So only 34.6% of males have received the HPV vaccine. Healthy People 2020 have a goal for 2020 to have 80% compliance. So as you can tell from the numbers I've just presented, we have some work to do in regards to compliance and protection preventive measures for the HPV infection and receiving the vaccine. So the strains that I mentioned, 16 and 18 previously, those two are responsible for over 70% of the cervical cancers that are diagnosed. So what does that mean? That means that the other 30% of cervical cancers are generally from other strains, if you will. There are 30% from other strains, but the majority come from 16 and 18. So there are other strains of HPV. There's over 130 strains, and 40 of those affect the genitalia in particular. Now, whenever you're talking about HPV infecting and affecting other parts of the body with cancer, 90% of all anal cancers come from the HPV virus. 69% of all vaginal cancers come from the HPV virus of various strains. 60% of all oropharyngeal cancers, 51% of all vulvar cancers, and 40% of all penile cancers. So there is a margin of error, a couple of points, give or take, on either side, which correlates for the 70% of all cervical cancers for those numbers in the significance. Now, the target population for this population intervention plan includes Hispanic females between the ages of 9 and 26 in the school system for Nueces County. So the risk factors for that population include Hispanic females have the highest cervical cancer rate of all ethnicities. They have the lowest compliance of Pap smear screenings. They also have the lowest HPV vaccination rate, and they also have the highest risk of cervical cancer compared to other ethnicities. So in Nueces County, contributing factors are that there's also a high teen pregnancy rate as well as a high Hispanic population. So the state, well, the national statistics show that throughout the United States, the overall Hispanic population is 17.6%. But when you look at the state of Texas, the population is higher for Hispanics with 38.8%. Now, since Nueces County is in South Texas, it is more heavily populated with the Hispanic population, 62.4%, hence the choice for Nueces County to have a high saturation of Hispanic population to do this intervention plan in to really be able to access and provide preventive measures for more of this particular uh, target population group. There are key stakeholders for the implementation of this project. It is the local health department, and the stakeholder as to what they would be doing is ordering the HPV vaccines, administer the HPV vaccines to that target population in the local schools, which would be your independent school district for Nueces County College, Del Mar College, and Texas A&M University for those between the ages of 9 and 26. Data entry for that would also be incurred by and responsible with the local health department through the MTRAC system that is the state of Texas database for immunizations. Pediatricians use this, the health department uses it, and the school system uses it to track immunizations. So there is a database in effect that is already able to provide uh, access and ease of tracking and documentation. So the local ISD and college and universities would provide not only the target populations to be identified, but also to give permissions to allow an educational video to those particular um, females between the ages of 9 and 26 that are of Hispanic ethnicity, and also to send out, after providing the video, educational video to those students, sending a packet out to the parents with a consent form, a survey to identify behavioral patterns and reasons and or barriers for not having their child immunized for the HPV virus, but also to have the consent so that the local health department can order the vaccine in advance prior to providing an HPV vaccine health fair for the designated target population. Also, educational information would be provided to the parents in the packet so that they could determine whether or not they do want indeed to have their child immunized, and the vaccines would be free to those that are participating so that there are less barriers involved in the decision making for them. So what barriers do we have when it comes to HPV vaccinations? There was a study of a multivariable analysis involving parental views and decisions as to why they did not like having their kids vaccinated in the school system, that identified certain things that were specially sensitive to them. And that was that they thought that their child would not want to receive the immunization without them, the parents, present. They felt that it would be difficult to keep up with the immunization record. Now, whenever you're talking about immunizing and not having an accurate record, since the state of Texas uses the database, electronic database, that would not be an issue. You also look at the other barrier of the uninsured were afraid to get a bill for that service. So whenever you're talking about the cost, since it would be provided free of charge, that would help sway and prevent any issues with not wanting to get the vaccine for that particular reason. Um, of all the vaccines that were offered in this particular study for the public schools in Colorado, those that were uninsured were more likely to be open to having vaccines provided in the school system versus those that were insured. Now, also, whenever you look at that data, there was a lower approval rating for the HPV vaccine in particular over other vaccinations that were also going to be offered. So when you're looking at the barriers, there is a need for additional education and the reasoning that perhaps needs to be addressed for why they choose um, to not want the HPV vaccine as frequent as other immunizations, even though, well, 53% in that study did not want were okay with the HPV vaccine being given. but 72% thought that it was important. So there's some education that is needed. When you look at the population health model and the theory that was chosen for this particular uh, population intervention plan, the health belief model was chosen. And the reason for that was because it involves one's perception of threat, susceptibility, benefit, and need for behavior and change. So basically identifying the reasons as to what the HPV immunization or the HPV virus can cause, what is the threat, and what are the benefits to having received protection from that particular virus. Also, the protection motivation theory is a perception of threat and susceptibility is understood as possible. So the behavior change occurs because they feel that they could possibly be exposed and or at risk. So the improvement is based on the need to protect themselves and or others. So the constructs of the health belief model include fixed and modifiable variables. You have the perceived severity, perceived susceptibility, perceived threat, cues to action, perceived benefit, perceived barriers, and likelihood of behavior modification of whether or not they would choose to go ahead and actually get the vaccination or allow their child to have the HPV vaccine. So here you see in the PowerPoint slide the health belief model implemented and broken down into what each one of those constructs means. So the fixed variables, you have the age, range, your gender, ethnicity, location, your modifiable variables, social norms, and cultural practices. That is very heavily um, considered whenever looking at the Hispanic population and how they choose to make decisions based off of cultural practices and perhaps even some misconceptions. So you have the perceived severity. It's not going to happen to my child. They think that their children are too young, they're not sexually active, why do they need it? You have the perceived susceptibility um, of sexually active early onset in the Hispanic population. If you look at the numbers, Nueces County has a higher teen pregnancy rate than the overall state of Texas, and Texas has a higher teen pregnancy rate than other states, many other states. You also have the perceived threat, the HPV exposure risks from unprotected sex, and then you have the cues to action, where received vaccine information and outreach helps break down those barriers and answers those questions that perhaps the parents didn't quite understand or realize the importance of. So when you look at the perceived benefit based on the cues to action, the parents can understand and perceive that there was a benefit, there is a benefit, and there is protection from HPV and common cervical cancers, from the most virulent ones in particular, and some other strains that aren't as virulent. Um, and then you have the perceived barriers. So the cost, access to care, and then the knowledge deficit, all three of which are going to be addressed in the program, providing the free vaccines, so cost is no longer a barrier. Access to care, it's provided in the school system through the local health department and also documented on a state database, so immunization tracking is very easy. And then also knowledge deficit, providing education to the students as well as to the parents to ensure that they understand the importance and the severity of what they could potentially down the line end up with a cancer from such exposure without protection. Also, the likelihood of behavior modification. The HPV vaccine is received, or the parents may just consider allowing their child to receive the vaccine. So, all considered and all reviewed discusses and identifies the steps to getting to a likelihood of perhaps increasing the uptake of the HPV vaccine among that target population with this population intervention plan initiated. So the implementation steps I'm going to review with you, even though I've already mentioned some of them, to set the goal for HPV vaccine compliance, 70% or greater HPV vaccine compliance among the target population in Nueces County is desired by the end of the 5-year project to get us closer to the Healthy People 2020 goal. But remember, we're starting at 15.1% compliance among Hispanic populations. Also provide HPV and HPV vaccine education to the target population and the students, and then provide HPV vaccines to the students in the school setting, which has already been discussed, in free of charge. So the females, again, between the ages of 9 and 26, Hispanic ethnicity in the Nueces County, residents in the school systems throughout this county. Also, parents are going to be surveyed for cultural beliefs and practices and knowledge of the HPV and HPV vaccine, and collect and analyze that data to better understand and establish a baseline of parental understandings or questions of HPV and the risk and HPV vaccine benefits. The surveillance plan for this implementation involves the initial survey data, which was mentioned about a baseline. So to analyze the data trends, and then of any misconceptions that they may have about HPV or the vaccine itself. Also identify culturally dominant trends that increase risk factors such as early onset of sexual activity, promiscuous behaviors, alcohol, all these different risk factors that can be involved. Identify key barriers, cost, access to care, missed provider opportunities, and lack of education or lack of outreach and community resources. So the survey, when surveying parents, it's going to be recommended that the parents are surveyed on an annual basis about HPV and HPV vaccine knowledge, and have perceptions, see if the perceptions have changed since receiving the education. Have they allowed their child to receive the vaccine? And did they complete the 3-part series for this vaccine instead of just getting 1 or 2? Did they get all 3? And then also track the HPV vaccine compliance through the MTRAC for target age groups. And then compare the data before the project began for that age group, and then compare the data to younger age groups not in the target population, and then compare the data to the state and national compliance rates for the target population, and then continue to track annually for the full 5-year period. So what assumptions are involved in this project? They are, many parents believe their child is too young to receive the vaccine since they are not sexually active, which I had mentioned previously. Those exposed to HPV strains 16 and 18 are at greater risk of getting cervical cancer than those not exposed to HPV or those who have had the HPV vaccine. And then a sensitization to education and education campaign will provide the foundation for positive behavior changes and increase HPV vaccine compliance rates. So the confounding factors, which were briefly touched on earlier, include multiple partners, risky behaviors, substance abuse, other sexually transmitted infections that contribute to abnormal pap smears findings, and then your familial inheritance of genetic mutation for cervical cancers are also included in this confounding factor that may be outside of the range of HPV exposure in particular. So the evaluation process is going to be done initially after the health department HPV health fair, and then annually thereafter for the parents, for those that are involved in the program, as well as any new ones that come in, all the way through to the 5-year period, to provide educational information to the students and the parents, to monitor the parental beliefs and knowledge, assess current HPV vaccine uptake, and then to monitor PAP results and monitor cervical cancer incidence and mortality. So in translating these findings, addressing barriers are cost, immunization accuracy tracking, and educating parents on benefits of the vaccine. And that will also help provide an environment of empowerment and behavioral changes for an increase in the HPV vaccine and compliance. So in improving the compliance of the vaccination from today's 15.1% for the Hispanic population overall to achieving the goal of 70% or greater, which gets us closer to the Healthy People 2020 goal of 80%, the success in the program would be a significant shift in Hispanic population disparities and closing that gap related to HPV exposure and um, cancers and cervical cancers. The impact to follow and analyze improved outcomes from this increase in HPV vaccine compliance and uptake would include less HPV infections, less abnormal pap smears, less cervical cancers, less cancers elsewhere in the body caused by HPV, and decreased disparity gaps between ethnicities. So the improvements in the patient outcomes will encourage improved health policies and perhaps even encourage and or trigger states to pass laws to allow immunizations to be provided in the school setting. Here are my references, and that's it. Thank you very much.